Hey everyone, welcome to the Happy Flosser podcast. My name is Billy Luntz. I am your host, and I'm here to talk to you about all things dental hygiene to support you on your journey through the dental hygiene program and beyond. I hope you are having a fantastic week. And for some of you, this is your very first week starting back for your spring semester. And maybe this is your last semester, dare I say, or maybe it's your second semester. It does not matter where you are on your learning journey, as long as you are doing things like listening to this podcast and investing in some good habit stacking to learn all of the challenging information that you need to know in dental hygiene school. Today's episode, we are going to be talking about neuroanatomy of pain control. And what I really want to do is help you connect the dots from theory to clinical practice. Because what oftentimes students have challenges with is learning some of the information. And some of this stuff you learn in anatomy and physiology. And you might not be able to connect the dots very well on why did I have to know all of that stuff? And then you start learning about local anesthesia and you take pharmacology and you start learning about the drugs and the interaction with the central nervous system and the peripheral nervous system. And then you kind of have to dig way deep into your brain, almost to your soul, to kind of regurgitate that information and try to make sense of it all. So I'm hoping that this episode will just be a really straightforward, um, just the basics, right? So break down the neuroanatomy of pain control in a way that really helps you understand why local anesthesia works, how those nerves transmit the pain, and then what clinical considerations you must think about when you're applying this knowledge chairside with your patient. Because we do connect foundational neuroscience to everyday clinical decisions that we make. And honestly, at this point, you're probably at the memorization phase. And before you know it, before long, it won't take long before it's all just kind of part of what you do. So, why does this matter in dental hygiene? Well, pain is probably one of the biggest barriers for our patients in order to build trust and to get them to be compliant with routine care. We want our patients to come back and see us. So, oftentimes, it's important for us to really understand the neuroanatomy behind pain control so that we can deliver safe and effective care to our patients. And instead of you just saying to yourself that you know all the landmarks and the injection sites and you know how much local anesthesia to give, you actually understand what you're targeting and how it works, right? What you have to know as a student. That's super important for you. So let's talk about the neuron. You have sensory and motor neurons, right? The neuron is the basic unit of pain transmission. So remember, you've got the dendrites and then the little cell bodies and the axon and the synapse. I hope all of those things, when I just said all of those words, you were like, oh, yeah, yeah. Oh, yeah, yeah, that's right. So remember those sensory neurons, it's that nucleus and cell body, it's like kind of located more in the middle. So the stimulus travels right to the brain, and so it's located a little more in the middle. And then when you get to the motor neurons, it's a little closer to the nucleus. So that stimuli travels from the brain, right? And then it goes into there. So the sensory neurons, they carry the pain signals from the periphery of the body, right? All the limbs to the central nervous system. And you have those myelination and node spaces, right, between them that are going to carry and transmit that information, right? I'm going to tell you a word that hopefully you remember from when you took anatomy and physiology. The myelin nerve fibers, right, along those axons between the Schwann cells, hopefully you remember that word, is a little gap known as the nodes of Ranvier, right? And so the action potential, the impulse moves along the myelin nerve before leaping from one to the next, right? That's the saltatory conduction. So when we're thinking about the myelinated nerve fibers for local anesthesia, I want you to think about those A delta fibers. Remember, there's like 4 different kinds. And those delta fibers are the fast ones that have the sharp localized pain transmitters there. So the C fibers, those are more of like the slow, dull, um, throbbing pain fibers. So why does this matter? It matters because in local anesthesia, we're blocking both of those types of pain fibers. We're blocking the A delta fibers and the C fibers. And those C fibers, those are the hardest ones to anesthetize, just so you know. There are actually 4 types of A fibers. We've got alpha, beta, gamma, and delta. So those are the largest fibers, and they're either motor or sensory, as you know, and they're myelinated. And those are our fast, sharp, localized pain ones, right? They are responsible for muscle and body movement. The betas help us with awareness of position, with touch, with pressure. All of this is important in dentistry, right? The gamma ones, those are they help us with keeping our muscle fibers taut when we're contracted, preserving their stretch sensitivity. And then our our A fiber deltas, those are for sharp stabbing pain and cold temperatures, and they're the smallest diameter ones. Those are definitely prevalent in dentistry. I have to mention the B fibers, though. Those are those medium diameter fibers, and they are motor fibers associated with the visceral sensory. So when we get to the C fibers, right, the C fibers are the ones also found in the oral cavity. So the A and C fibers are in the oral cavity and the dental pulp. The C fibers are most oftentimes in the dental pulp, and that's why they have the slow, dull, throbbing pain. So those fibers require more local anesthetic, right, in order to anesthetize. So let's talk about the trigeminal nerve, right? That's the star of dentistry, right? There's 3 divisions. It's the largest of the cranial nerves. It's kind of like the big kahuna of the cranial nerves. So this guy has 3 main divisions. V1 is your ophthalmic, V2 is your maxillary, and V3 is your mandibular. So here's your 3 main branches of the biggest cranial nerve. And it's kind of a big deal in dentistry. So super important for us to be really good at providing local anesthesia and comfort to our patient, understanding how pain signals travel, understanding what we're actually doing on a microscopic level when we are giving local anesthesia to our patient. So we want to know that pain begins at the nociceptors in the pulp, the gingiva, the bone, or the mucosa, and they travel along those peripheral nerves, right? The trigeminal ganglion to the brainstem, thalamus, and cortex. So understanding these pathways really helps you predict where you might have failure to get local anesthesia to work. So why do we do an IA nerve block, right? Think about the sodium channel blockade. So local anesthesia prevents sodium influx. So there's no action potential. And when there's no action potential, there's no pain signal. So it works best on those small myelinated fibers, those A delta, but requires higher concentration for the C fibers, right? The ones found inside the pulp. So those are really important considerations when you are trying to get pain under control with your patient. So the other thing we always talk about is success. Do I successfully anesthetize my patient, and can I manage their pain well so that they come back and they have a good experience while they are in my chair? So it starts all the way back in A&P1, where you're learning about the central nervous system and the nerve fibers. But then all the way through your learning journey, at some point, we want you to be able to recall this when you start talking about local anesthesia and some of the factors that affect your success in providing local anesthesia to your patient. It's important for you to know things like tissue pH, right? If your patient has an infection, that equals more acidity in the area, which decreases the effectiveness of the local anesthesia. The diameter of the nerve that you are trying to anesthetize also plays a factor. The myelination, the vascularity, And let's not forget the technique and the deposition accuracy. Are you on the right spot? Are you using the right anatomy? Do you have the right angulation? Are you using the right technique with your injection? And then we could go a whole nother episode or two or three or six talking about vasoconstrictors and why epinephrine matters. We know that soup to nuts, when we're talking about nerves and neuroanatomy, that the epinephrine prolongs the duration. It reduces the bleeding and it makes the anesthesia feel more profound for our patient. Now, just as a review, when we're doing maxillary injections, we've got the choice of the PSA, the MSA, the ASA, the greater palatine, the nasopalatine, right? And the maxillary anesthesia, pretty easy and straightforward to learn, right? It's got thin cortical bone and nerve proximity, which I can't talk today. So when we have, maybe we're off a little bit with our injection, we know that the deposition is still going to reach where it needs to go. Whereas with the mandibular injections, it's a little trickier because of the thick cortical bone and the anatomical variations between our patients. But our choices, for the most part, are your inferior alveolar nerve block, your buccal, your lingual nerve, right, your long buccal, your mental incisive foramen. All of those are kind of your choices. It has to be all of the holes in there because of the thick, dense cortical bone. You have to go to all the foramens there. So it's important for you to really think about your patient's anxiety level and provide them with reassurance, right? So some of the precision that you want to have over the speed, making sure that you're aspirating with your patient, that you're palpating all of the anatomy correctly, and that you're doing a slow deposition when you're doing it. And you're going to come across that patient where you don't get them numb, right? Think about your anatomy, think about your technique, think about the type of anesthesia that you're using, the amount of anesthesia that you're using, and evaluate the pH of your patient. And make sure that you can help your patient differentiate between pressure or pain. Sometimes your patient might not understand that. They just feel something, so they just immediately associate it with with pain. So what I will say is, here's your key takeaway, right? Know the nerve, know the injection associated with the nerve. Pain control is not just about science, it's about communication with your patient. Understanding the neuroanatomy really helps you. I'll tell you what it does. It helps you build your confidence. Because guess what? You have injection anxiety just like your patient. Yours is just different anxiety. Your anxiety, oh my gosh, there's so many things you're worried about when you're giving an injection. so, so there's anxiety for you. For me, I don't want my patient to have an allergic reaction. I want to make sure that I don't hit bone, that I get my deposition in the right angulation, and I'm actually successful on the first try. Those are the things that kind of go through my head. And for you guys, you want to make sure that you have as much knowledge and information in front of you to help you with the process so that you can help focus on your patient and reduce their anxiety. And sometimes that can be really hard because you're focused on your technique and did you get the right local anesthesia? Did you get the right size needle? Did you palpate correctly? Do you have the right topical? Did you look over the medical history? There are 8 million things that you're thinking about. And unfortunately, at the bottom of the list is your patient's anxiety level or their gag reflex or their really strong tongue. But those are all factors, right? In part of the pain control process is successfully anesthetizing your patient. But I promise you, if you start with your basics of neuroanatomy and build your confidence from there, really understanding what you're doing goes a long way in the whole process. And then the other thing I will say is I would review that trigeminal nerve so many times while you're in school. Before you're going to give an injection, you know that you have a patient in your chair who's coming in and you're going to be doing a nerve block or you're going to be giving local anesthesia anywhere, really. Review your trigeminal nerve, review the V1, V2, V3, review all of the branches, because the more you visualize that and the more you connect that with the direct patient care the next day and then come back to the information, It's not just going to be a test question, a multiple choice question. All of that content will eventually, at some point, with all of that habit stacking, become part of your routine learning that you're doing over time. Because there's so much that builds on that foundational knowledge from A&P 1 and 2, and you don't even realize it. So I hope today I've at least jogged your memory of the importance about learning about a neuron and understanding how the anatomy matters, right? The nodes of Ranvier, right? You got to know what that is. That's actually where the local anesthesia gets absorbed. And so you have to have penetration around the nodes of Ranvier. And if you have to take a moment and go back and look at those neurons, then please do that so that it will help you become that in-depth, knowledgeable dental hygienist that you need to be. And it's also going to be a great way to prepare you for board. So why not do it, right? All right, guys. I hope you have a fantastic week. If you are not following me on social media, I am on TikTok at The Happy Flosser. I am on Instagram at The Happy Flosser. I put educational videos on there every week. I try to do like Motivation Monday, Typodont Tuesday, Wisdom Wednesday, Talking Teeth Thursday, and Flashcard Fridays. I don't know what I do on the weekends. I actually just started going live on the weekends as well. But whatever resources you need, please reach out. You can always click the link in the show notes and reach out to me. If there's something you're just having a really hard time with and you need a visual, I'll put a reel together. Don't even worry about it. Just send me the information. I'm always trying to help students just a couple minutes at a time, honestly. That's what this podcast is about. That's what TikTok and Instagram are about. It's about short incremental learning because that's how you get the knowledge understandable, right? Hear it, you forget it. See it, you learn it. Do it, you understand it. And so I want you to be able to hear it, see it, and do it with everything that you need to know in dental hygiene school. And that's why I'm here. All right, guys, have a great week. I'll talk to you soon. Bye-bye.